Good morning, team. This is Dr. April Dominick. I am on faculty with the ICE Pelvic Division. Today, we are chatting about prehab for a prostatectomy surgery. Why is prehab important? And what should be included in your PT session with that pre-prostatectomy client? This topic, it is so near and dear to my heart. It's because these humans just don't have the treatment or education that they deserve prior to going into these surgeries and afterwards when they come out. And if I can convince you why it is so important to be able to connect with these humans and to even just educate them on, hey, there is help for you. There's pelvic floor muscle training that can be done, education about behaviors, whether that is you actually doing the PT session or you referring them to someone else, it can have incredible outcomes for them post-op just because they are aware of pelvic floor physical therapy for their surgery, the prostatectomy. So let's dive into what a prostatectomy surgery actually is. It is something to treat prostate cancer, and that's going to be by removing part or the full gland of the prostate. They're also going to remove surrounding tissues and seminal vesicles. The gold standard for surgery is a radical prostatectomy, where they remove the entire prostate gland. I didn't have a walnut, so here's what we're working with. This fig represents the prostate. So let's run through some real estate of where everything is situated in someone with a prostate in terms of the pelvic floor and the organs. So we have our bladder here, and then we have the bladder neck with the urethra that goes through our prostate. And this is going to be representative of the urethra itself. So the urethra goes from the bladder neck through this fig or the prostate and then down into the penis. And that is how everything is set up. With a prostatectomy, after the prostate is removed, that extra support around the urethra is now lost. And the remaining bit of that urethra now needs to be reconnected back to the bladder. This reconnection, we can think about it like a bridge, or a fancy term is the anastomosis. And that anastomosis needs time to heal. So a Foley catheter is placed in for about 5 to 10 days. That means that the bladder is, or the urine is emptying passively. The bladder is not doing its job. It's off on vacation. And then once the catheter is removed, the bladder acts like it forgot how to start or how to store urine. It doesn't know what to do with it. And so we have a lot of urinary leakage. So among other things, this is why urinary incontinence or urinary leakage is a major side effect with these prostatectomy surgeries. Post-op, the external urethral sphincter is relied on for maintaining continence. So good news for us, the pelvic floor muscles help to close that sphincter and keep pee in until it's appropriate to release it. And that's why pelvic floor muscle training with physical therapy can be so important pre-op and post-op, at least from the bladder side of things. So who does the prostatectomy surgery affect? Well, obviously those diagnosed with prostate cancer. It is the second leading cause of death from cancer in males. It's going to affect our individuals who are older than 50 years old and who are African American. So if you think about who you are treating currently, if you're treating individuals who have prostates who are older than 50, 1 in 8 of them are probably going to have some run-in with prostate cancer, whether that's treated with a surgery or not. That's where you come in. You could have such a profound effect with these individuals just by educating them that pelvic floor muscle training exists. And whether you're doing the treatment or you're referring out to someone else, you can have such an incredible impact on their post-op outcomes potentially. So We talked about with a post-prostatectomy, we talked about that surgery can result in urinary incontinence or leakage. It can also affect sexual function. There can be reduced physical function. Think about it. If you're leaking all the time, is that really going to convince or motivate you to go work out? For some, no. And then it'll also affect the overall health related quality of life. Take 65-year-old Phil. You've got a Phil in your clinic. You're already treating him for low back pain with his hikes and his weightlifting, say. And he went in for his annual physical, and then he walked out with a date for a surgery for a radical prostatectomy. Besides being in shock that he now has this potentially life threatening diagnosis, Phil comes in and is like, this happened. He's like, am I ever going to be able to hike with my hiking group and not be the person that smells like pee? Am I going to be able to be cool with being in the changing room in the locker room after my weightlifting session, like removing this soggy pair of underwear? Or am I going to be able to enjoy sexy times with his partner? Well, since you're here and you intently are listening to this podcast, your first line of question is, hey, Phil, did they recommend any sort of physical therapy for you, whether it's pre-op or post-op? And of course, Phil's like, "Ner." So you teach him that pelvic floor muscle training can be so effective and helpful, and play a huge role in those side effects that he's worried about. Y'all, what if we could have an incredibly bigger impact building the foundation, setting the stage for what to expect post surgery just with PT sessions? Clinically, I've been treating this population, hopefully, you can hear my passion behind it, for about 7 years. I've interacted with so many fills that come in, if they even get to me, right? Um, and they are just slapped with that surgery date. And the side effects are kind of breezed through during their appointment, it seems like. And their concerns aren't really heard, their well-being and their questions, they're just kind of like not given a lot of attention. I didn't always do pre-op sessions, but once I started, whoo-wee, I was just blown away by how different the clinical outcomes were in terms of improving, whether that was decreasing the volume of urinary leakage for some, or having them return back to their ADLs, exercise a little bit sooner. Um, the biggest thing, which was so powerful for me, is these people came in extremely uncertain, having no idea even why, if their doctor did send them to PT, why they were there. And they were just uncertain about these really scary side effects, about how maybe for the first time they were going to experience some sort of losing control of their bodies, from peeing unexpectedly to changes in their erections. And they walked out of that first session feeling a little more confident, a little more certain. And that is the power, I believe, of these pre-op sessions. And then from a research side of things, what's shaking out in the few RCTs that we have for these prehab sessions and their effects on prostatectomy, it's helpful in, some may be helpful in improving quality of life. They may affect a shorter hospital stay. They may reduce post-op urinary leakage in the short term. So some studies find around month 1, 3, or 6 that the individual is leaking less, meaning they're drier faster. Now, when you compare someone who had some pre-op PT to someone who did not, around 12 months, they are about the same with their rate. But I would argue that I bet folks are going to be a lot more satisfied if they did that prehab and they are drier sooner, right? So let's go into what a prostatectomy PT session entails before that surgery. We've got these sessions already in place for folks who are going in for surgery for their ACL repair, for their hip replacement. But just like we're fighting with our pregnant and postpartum population, we are somehow having to fight for someone to have a pre-op session for something like a prostatectomy And that impacts so many daily functions. So let's outline what is involved in that pre-op PT session. Again, you can educate someone on what to expect if you're referring them to someone to do this. So we'll go over subjective, objective, and the treatment. From an assessment side of things, from that subjective piece, what you can be talking to your patient about is what are their current bladder and sexual habits? How many voids do they have during the day? How many times do they go pee? Do they have an urge? Do they have urinary leakage or hesitancy? And there are some outcome measures that go over these things. The International Prostate Symptoms Score goes over those things, plus they ask about nocturia or nighttime urination. And then the NIH Chronic Prostatitis Symptom Index is another outcome measure. And I love it because it asks about the impact of these symptoms. How is it affecting your quality of life? Then you want to also ask about their sexual function. How would they rate their erection strength or their satisfaction with their sexual life? And from an outcome measure standpoint, you can give them the International Index of Erectile Function. This is something that asks them to rate qualities of their erection from the past 4 weeks. And then you want to also get a good idea of their current physical activity regimen. What a wonderful time to if they're already a little physically inactive, hey, let's like plug in for here's why it would be really great if you could up that physical activity, not just for that immediate post-op surgical outcome, but also, hey, we can lower all-cause mortality. And then from an objective side of things, so we went over the subjective. Objectively speaking, we want to get a pelvic assessment, whether that is over the clothes, external, near that midline, or it is a visual or tactile palpation, or an internal rectal assessment if that's what you're trained in. So we're looking for what's their awareness? Do they even know that they have this group of muscles that they can control called the pelvic floor? We want to be looking at their coordination, timing of the pelvic floor, and then also getting an idea of what is their breathing and bracing strategies for things that increase intra-abdominal pressure, like fitness activities or functional lifting of the groceries, coughing, running, weightlifting. Typically, this population tends to be a breath holder. So we're going to spend some time. There's just so much that we can do to help them in this area to help them have improvements in their methods with that. And then we also want to be doing some sort of general ortho screen because what if their hips are cranky? Obviously, that's going to affect pelvic floor, low back, and all those surgical outcomes. From a treatment side of things, so we went over subjective, objective, highlights from the treatment side of things, where we'll talk about education, what to expect post-op, and some homework for them to work on. Education. I cannot stress this enough. The education piece here is vital for affecting their outcomes and well-being. Let's educate them on the pelvic floor. Here's what it is. Here's the anatomy and physiology. Here's how it affects your penis, whether that's for sexual health or for the urethra for urination. Here is what happens during the surgery. Get to know the surgeons in your area and which methods they use. What are their outcomes, right? And then you want to be explaining the risk factors for these side effects like urinary leakage and sexual dysfunction. Non-modifiable factors. If you're older, it's not going to help you as much. And if you already have some reductions in urinary function, like you're already leaking, that is not going to help you on the backside. Modifiable factors, tons. So things like smoking, poor nutrition, that's going to delay healing post-op. Can we identify some current bladder irritants and reduce those immediately post-op? What about poor mental health? Things like low self-efficacy, or if they're experiencing anxiety or depression, helping them ID these things and finding them some psychosocial support to have upcoming for the surgery and post-op, so key. And then reduced physical activity. Hard health is heart health. What do I mean by that? Erections, ejaculation, is related to vascular health. Hard health is heart health. So, what affects our vascular system? Aerobic and resistance training, exercise. If we can have them and talk to them about how it's important and how increasing that physical activity is going to improve their physiologic resilience to the surgery itself and any complications that come up, mm, that is going to be having such a huge impact on their quality of life. Um, Regarding physical activity, in a 2014 RCT by Mina et al., they said they found that men who were meeting physical activity guidelines prior to surgery had greater health related quality of life at 6 and 26 weeks post op compared to men who were not meeting those physical activity guidelines. So, from a post op perspective, we want to tell them what to expect: urinary incontinence and sexual dysfunction. From the urinary incontinence side of things, they will have a Foley cathetered in for 5 to 10 days. Remember, the bladder doesn't work during this time. Once that catheter is removed, we got to retrain that neural pathway that to help control the bladder, so that they know, oh, my bladder is filling, or this is how I'm going to stop that leakage from coming out, and how to fully empty the bladder. Another huge tip: have them bring a hygiene product, whether that's a pad or a diaper or something, with them to the hospital so that when they are discharged, they have something, to help protect them on their way home or on their way to the store to grab their meds. And then urinary incontinence could be present from a couple of months to a year post-op. We see a significant improvement in that 3 to 6 month range, but it could be affected by things like, hey, it gets worse at the end of the day because the pelvic floor muscles are tired, or with transitional movements like sitting to stand. So, working on these movements with them is going to be super helpful. And then pre-op. And then maybe talking to them about how, if you're not going to see them for 10 days or so post-op, we may be using the pad weight or the number of pads in a 24-hour period as a marker for our progress. So just having that in the back of their mind. When it comes to what to expect from a sexual function standpoint post-op, it can take up to 2 years to recover to baseline function from an erection standpoint. And we want to set these expectations. From an ejaculation standpoint, dry ejaculate is going to happen now because those seminal vesicles were removed, and that's what helps produce that ejaculate. There may be some changes in their orgasm sensation. Erections, it could be dependent on surgery outcomes. How much nerve sparing was there in that procedure? They have the potential to get better with this, especially with pelvic floor muscle training or things like pumps. And then loss of penile length. This is something that we want to let them know can happen, so they don't get a little surprise. Homework wise, we want to address any of those pelvic floor deficits we found from that objective piece, especially that breathing and bracing strategy. We can do that with biofeedback, whether that's with a mirror, with a palpation from the therapist or from them, and just to really improve their awareness and coordination there. And then giving them cues that connect them to the pelvic floor. Evidence supports, hey, pelvic floor contractions with the following cues, like shortening the penis, though I've been told nobody wants to have that. So something like nuts to guts or stopping the flow of urine is great for that. One side of the range of motion, the contraction side of the range of motion of the pelvic floor, and then something for the relaxation side, like let the testicles or base of penis hang loose. I did an Instagram post recently, so you can check that out on the ICE or Revitalize Pelvic Physio page. And then we want to be, for homework, modifying their poor lifestyle habits. Can we reduce those bladder irritants, processed sugar? Can we increase your physical activity and mental health? And then finally, we want to be scheduling their follow-up visits on the calendar. So whether that's for pre-op, a couple more sessions, or as early as 10 days, once that catheter is removed, they can pop back into your office. So, I hope you found that information helpful. We reviewed how prevalent prostate cancer is, especially for those who are 50 plus. We know that radical prostatectomy is the gold standard for treatment. Two major things that are affected post op are urinary incontinence and erectile dysfunction. Pre-op PT sessions are fairly new, but we have some evidence that says, hey, those who partake in pre-op sessions are drier sooner than their counterparts. And then from a PT session standpoint, thinking about asking what their current bladder and sexual function is, asking them about physical activity, mental health, objectively getting a measurement of the pelvic area, and helping them connect with that area a little bit more. Treatment wise, we want to really harp on that education about what the pelvic floor is, how it can help with their function, and also what to expect, possible side effects, modifiable risk factors, and then giving them homework to work on those deficits. And then finally scheduling that additional follow-up before surgery, and then getting their post-op session on the calendar. My next podcast, I'm going to go into detail on what a post-op session post-prostatectomy looks like. So tune in for that. And then if you want to learn more about pelvic floor examination, join us live. We have our next two courses. One is July 20th, 21st in Cincinnati, Ohio. And then July 27th and 28th, we are going to be in Laramie, Wyoming. If you're wanting more of a virtual option, we have our two different courses that are 8 weeks, L1 and L2. And in L2, we go over the male pelvic health conditions as well. Thank y'all so much for tuning in from my prostate/walnut. Happy Monday, and I'll see you next time.